Now we are going to completely discussing about the pathological conditions. So the first pathological condition which we are going to discuss is the vertical fusion defect. Guys, what's happening in the vertical fusion defect? We all know that there should be a vertical fusion. Whenever the Mullerian ducts are not vertically fusing with the urogenital sinus, what happens? There will formation of a septum. Guys, please concentrate. Mullerian ducts, okay, so this Mullerian duct, it have to fuse with the urogenital sinus. For example, something like this. So Mullerian duct is fusing with the urogenital sinus, so that you will be having a canal. Now whenever the fusion is not happening properly, what you will have? You will have a septum. So this septum is present transversely. So transverse vaginal septum, this thing, okay, which you can see over here. Transverse vaginal septum is an example of vertical fusion defect. So how a female is going to present to you if she is having this transverse vaginal septum? Very simple. Whenever she is having this septum, abnormal septum, do you think that her menstrual blood is going to come out of the vagina? Absolutely no. Her menstrual blood is not coming out. Why? Because there is this obstruction. Whenever that menstrual blood is not coming out, does she think that she is having this menstruation? No. She thinks that she is having amenorrhea, and that too primary amenorrhea. Okay, from beginning itself, she is not having this amenorrhea. Okay, please concentrate that the clinical feature, most common clinical feature is going to be the primary amenorrhea. And the most common location for this transverse vaginal septum is near the external cervical os. Guys, please concentrate in this image. I think you can see this image. It's very clear that all this menstrual blood, okay, all this menstrual blood is getting accumulated over the septum and it is not coming out. See, there is this menstruation happening, but that menstrual blood is not coming out. So can I call it as cryptomenorrhea? Yes, absolutely. So presence of this transverse vaginal septum is going to be a cause for the cryptomenorrhea, the menses which is hidden. So whenever the blood is unable to come out, all this blood is going to accumulate here in the vagina. So there will be hematocolpos. Okay, hematocolpos means blood in the vagina, hematocolpos. And this blood can back up and it can cause hematometra, hematosalpinx, which means the blood, now all this blood is getting accumulated in the uterus, and this blood might also end up in the fallopian tubes. Hematosalpinx, hematometra means blood in the uterus, blood accumulation in the uterus, and she will have this monthly cyclical pain. How she is going to present to your clinic? She is going to present to your clinic that by the age of 15, now she will say, doctor, I am not having this periods. Okay, I have reached the puberty, but still my periods are not begun. But every month I used to feel like I'm having this very much pain. Okay, pain is there, cyclical pain is there, but she is not having menses. Actually, she is having menses, but which are not coming out. Okay, that's the problem. Now, what about the secondary sexual characters? Secondary sexual characters are absolutely normal. Why? Why? Because normal estrogen production is there, that causes the breast development, and even there is this normal androgens in her that causes the pubic hair and axillary hair development. So secondary sexual characters are absolutely normal. How she is going to present? Primary amenorrhea. She have this puberty, but she haven't started her menarche. Okay, this is going to be the primary complaint. If you have done the ultrasonography, what you will see? Uterus is normal, ovaries are normal, cervix is normal, vagina is normal, everything are present. But you might find there is this blood accumulation in the uterus cervix. Okay, hematometra, hematosalpinx. So this is something about the vertical fusion defect, and you can simply take out the septum. Then a problem will be resolved. Okay, after the vertical fusion defect, that is a transverse vaginal septum. Now we will discuss about the lateral fusion defect. What does it mean by lateral fusion defect? As we all know that both the Mullerian ducts should have to fuse laterally. So if they fuse properly, then only you will have one uterus, one cervix, one vagina and two fallopian tubes. If they are not fusing laterally properly, then there will be a lot of associated problems. Now, all those problems was classified by the American Society for Reproductive Medicine, ASRM, into different classes, which we will discuss now. So the first class is complete Mullerian agenesis. Okay, let's talk about that first. So class 1 is Mullerian agenesis, which is also known as MRKH syndrome, okay, Mayer-Rokitansky-Küster-Hauser syndrome, which is not like, knowing this name is not that important, but Mullerian agenesis, the concept is very, very much important. What is the concept? Both the Mullerian ducts absolutely gone. Agenesis, there is no genesis or there is no expression or development of the Mullerian ducts. If the Mullerian ducts are not expressed, means the derivatives of the Mullerian ducts are also not there. What are the derivatives of the Mullerian ducts? Uterus, fallopian tubes, cervix and upper two-thirds of the vagina. Do you think that in a female where this Mullerian ducts got totally gone or agenesis, do you think these structures will be present? Absolutely no. These structures are not present. So there is this absence of the uterus, fallopian tubes and upper two-thirds of the vagina. Okay, these structures are completely absent. But the karyotype is something normal. Okay, there is no problem in her genetics. It is 46 XX. 46 chromosomes are there and both the X chromosomes are there. Now phenotype, she is just looking like a female. There is no problem with her. Okay, she is absolutely female-like. Now other organ anomalies, organ system anomalies, what are they? See, renal agenesis might be there. Okay, yeah, renal agenesis, horseshoe kidney might be there, hemivertebrae scoliosis and cardiac defects can be seen in a female who have this Mullerian agenesis. Why? Guys, the concept is very simple. For example, this is the Mullerian duct. Okay, this is the Mullerian duct. And what's happening with the Mullerian duct? It's not getting expressed or there is complete agenesis, non-development of the Mullerian duct. See, there is non-development of this Mullerian duct. Do you think that only Mullerian duct is not developing? For example, there is some blast in certain area, for example. I don't expect to happen, but there is some bomb blast. If there is a bomb blast in certain area, do you think one particular area will be damaged? No, a whole lot of area will be damaged. In the same way, if there is some mutation or whatever, if the Mullerian ducts are undergoing agenesis, okay, non-development, do you think only Mullerian ducts will go because of the mutation? No, the surrounding areas might also get affected. So here also, not only Mullerian ducts will undergo agenesis, the surrounding areas, the surrounding tissues will also develop. So that can cause renal agenesis, horseshoe kidney or cardiac cushion defects, vertebral defects like scoliosis, hemivertebra and all the things. Okay. Now the question is how she is going to present to the clinic. Now she is going to present to the clinic at the age of puberty, something around 15 or 16 years, the chief complaint of primary amenorrhea. Okay, primary amenorrhea, she haven't started her menses yet. She is almost 16 years, but no menses have started. But what about the secondary sexual character? Her breast development is absolutely normal. Her axillary hair development is normal. Pubic hair development is normal. Why? Why? Because, please concentrate guys, secondary sexual characters, they are coming from the ovaries. Ovaries are absolutely normal. Ovaries are not the derivatives of Mullerian ducts. Please concentrate. Ovaries, they are forming from a structure known as a genital ridge, something totally different. It's not a Mullerian duct derivative. So, ovaries are there. Whenever ovaries are there, estrogen is there and that estrogen can make up the breast. But here in this patient, as there is no uterus, no cervix, no upper two-thirds of vagina, no fallopian tubes, can she have menses? No. Secondary sexual characters are normal, but primary amenorrhea. Okay, this is how the patient is going to present. Same just like transverse vaginal septum. Even the patient with the transverse vaginal septum also going to present same like this. Here also same complaint, primary amenorrhea. How to differentiate? There in transverse vaginal septum, if you do the ultrasonography, you can see the uterus, cervix, fallopian tubes and vagina. Everything is normal. But here, upon doing ultrasonography, you can't find uterus, cervix, upper two-thirds of the vagina and fallopian tubes. Those structures are absent. Even here, in the laparoscopic view, it's very clear that the ovaries are present. You can see ovaries over here. Okay, right and left ovary are there. But where is the uterus? Okay, where is the uterus? Uterus is absent. That's the primary pathology here with the Mullerian agenesis. Even here, you can see ovaries. Okay, left ovary is there, right ovary is there, and there is no uterus. Okay, no uterus. That's what is the Mullerian agenesis. Okay, so the chief complaint is primary amenorrhea. The secondary sexual characters like breast development, pubic hair development, and axillary hair development is absolutely normal. And if you do this rectal examination, Okay, in unmarried girls, you are not supposed to do the perspicuum or vaginal examination. So if you do the rectal examination to feel the vagina, vagina is felt like a blind pouch. Why? Why? Because the upper two-thirds of vagina is gone. Why? Because the upper two-thirds of vagina is a derivative of a Mullerian duct. And if you are doing this ultrasonography, there is no uterus, no fallopian tubes, no cervix, and no upper two-thirds of the vagina. This is how the ultrasonography gives you the data. Now, after this, let's talk about the treatment options. What you can do with this female. She is not having the uterus, fallopian tube, cervix, and upper two-thirds of the vagina. Now, should you have to do the uterine transplantation or something like that? No. Now, what we can do here is a vaginoplasty, recreate her vagina. Our vagina is something like a blind pouch. Only the lower part of the vagina is developed, something like a little dimple, but it is also not properly developed. So, what you can do is recreate her vagina, that's by the vaginoplasty, so that she can have a normal intercourse after she marries. Now, what about her likely motherhood? Can she have babies? Absolutely, she can have babies, but not by herself. Why? Because she is not having the uterus. What she is having is the ovaries. If she is having ovaries, then definitely she can have that ova. Now, what we can do as a doctors, we can collect those ova and we can fertilize it with the partner's sperm and we can put it in the surrogate mother's uterus. So, she can be a mother, genetic mother, but she have to go over the surrogacy. So, please concentrate, guys. Female with MRKH syndrome, Mayer-Rokitansky-Küster-Hauser syndrome, can have their biological offsprings, genetic offsprings, because they have normal ovarian function. Again, I am repeating, ovaries are not absent in Mullerian agenesis. Ovaries are derived from genital ridge. Okay, so they are capable, they are incapable of bearing a child because they are not having uterus due to absence of a uterus, so they should undergo surrogacy. Okay. Now, after Mullerian agenesis, now let's talk about the class 2 of the ARSM. Okay, ARSM classes. What is this class 2? Complete developmental arrest of one Mullerian duct. Okay, out of the 2 Mullerian duct, 1 Mullerian duct is completely absent. So, 2 Mullerian ducts should have to fuse, and then you will be having 1 uterus, 1 cervix, 2 fallopian tubes, and 1 vagina. Out of 2, 1 is gone. So, what you will have is a 1 Mullerian duct, and that 1 Mullerian duct will develop and form half-half structures. Something like there will be half uterus, half cervix, half upper vagina, and 1 fallopian tube will be present. Okay, a very much atrophied thing. Okay, you can clearly see that there is only 1 fallopian tube and a very narrow uterine cavity and the vagina. Everything is half of the normal. Now, guys, here I just want to give you some more important points that sometimes there can be a rudimentary horn. I will show you how actually that rudimentary horn looks like. But before discussing about the subtypes and all, it's very much clear that unicornuate uterus. Okay, now I am saying this condition is known as a unicornuate uterus. Unicornuate uterus is a condition in which 1 Mullerian duct was completely gone. Whatever you have or whatever the female has have developed only from 1 Mullerian duct. Okay. Now, having such unicornuate uterus or the banana-shaped uterine cavity. Okay, having this unicornuate uterus will be a risk for developing endometriosis. Okay, why? Because having this uterus may cause the regurgitation. Okay, the menstrual regurgitation that may cause the endometriosis. A preterm labor, there is no enough space for the development of the baby. That can cause preterm labor. Most of the students will think that, okay, can she have a normal pregnancy? Yes, absolutely, she can have a normal pregnancy. There is no doubt. Okay, see, there are chances of preterm labor, there are chances of the recurrent abortions, but still 50% of the time she can have a normal delivery. There is no doubt. Okay, because of not enough space, she can have this breech presentation, ectopic pregnancy, and first trimester abortions can happen, and renal abnormalities can be seen. Guys, they will ask you, what is that uterine anomaly? Okay, what is the most common uterine anomaly with which highest amount of or highest chances of renal agenesis is seen or renal abnormalities is seen? It's the unicornuate uterus. Very much important MCQ. Renal abnormalities a renal agenesis is associated with the unicornuate uterus, but also remember that complete Mullerian agenesis can also present with the renal abnormalities. Okay. After seeing this, let's talk about these rudimentary horns and subtypes of the unicornuate uterus. See, this is the classical variant. Now let's talk about the subtypes. Guys, what you are seeing here, this image A is a classical variant, only one fallopian tube, okay, one fallopian tube and very much half a cervix, half a vagina, half a uterus, okay, very much half of the number. Now here, what you can see here is having this image B is having this rudimentary uterine horn, okay, see this rudimentary uterine horn which is not having any cavity. There is no endometrial cavity. Endometrial cavity is not there. Okay, well and good. But see here, the image C, you are having this rudimentary uterine horn with the functional endometrial cavity. What does I mean by functional? There is this endometrium growing into this rudimentary horn. Okay. Now, image D, this is something very much important. See, this is a unicornuate uterus. But here, you are having a rudimentary horn, that too it is having a functional endometrial cavity. Okay, so what's the problem? But that functional endometrial cavity is non-communicating with the normal uterine cavity. See, this is something normal uterine cavity. Okay, it's not a normal uterine cavity, but this is a regular uterine cavity of a unicornuate uterus. Now, this rudimentary horn, it's non-communicating. Whenever it's not communicating, what's the problem? See, if it's not communicating, every month this functional endometrium, it will shed and there will be menstruation. But as it is non-communicating, all this blood will accumulate and cause hematometra that will cause pain. Cyclical dysmenorrhea will be pain. Okay, cyclical dysmenorrhea will be there. So please concentrate here. Non-communicating rudimentary horn can cause cyclical unilateral dysmenorrhea. Okay, unilateral, especially on this side. Unilateral dysmenorrhea due to hematometra. This is something very, very important. So we have seen class 2. Now guys, please concentrate that in order to understand the uterine anomalies, we will be doing a radiological investigation known as hysterosalpingography. What exactly is hysterosalpingography? Now I am going to show you in this video. In hysterosalpingography, we are going to put a radio-opaque dye or radio-contrast dye into the uterine cavity. After sending this radio-contrast dye into the uterine cavity, we are going to take a series of X-rays. Now, in the X-rays, you can see how the uterine cavity is there. Okay, whether it's normal or whether there is any uterine anomaly or not. Okay, now please concentrate and watch this video. See, with the help of Leach-Wilkinson's cannula, we are sending this radio-opaque dye, and this radio-opaque dye is going to fill the uterine cavity as well as the fallopian tubes. Now, this radio-opaque dye is going to fall into the peritoneal cavity. Now, as there is this radio-opaque dye in the uterine cavity and the fallopian tubes, if you take X-rays, now you can see something like this. For example, in the condition of unicornuate uterus, you will have the hysterosalpingography, images, something like this. For example, please concentrate. See, you are seeing only one horn of the uterus, okay, only half of the uterus. Okay, here also you can very clearly see this banana-shaped uterus. Okay, let me clear it up so that you can see clearly actually how it should be there. You should see a uterine cavity, uterus something like this. Okay, but here it's very clear that you are seeing only half of the uterus. Okay, very small uterus. Okay, so this is how it will look on the hysterosalpingography, and we are going to see all the hysterosalpingographic slides in different conditions. Okay, now please concentrate, guys. We are discussing about the class 3. What is class 1? Complete non-development of the Mullerian duct. That is complete Mullerian agenesis. What is the class 2, guys? Class 2 is a unicornuate uterus where there is only development of one Mullerian duct and there is complete non-development of the other Mullerian duct. Now we are going to discuss about the class 3 where there is non-fusion of the Mullerian duct. See, both the Mullerian ducts are there. There is no doubt. This Mullerian duct is going to form one uterus, one cervix, one upper vagina and one fallopian tube. And this tube, okay, or this Mullerian duct is going to form one uterus, one cervix, one vagina and one fallopian tube. Both are there, but they are not fusing. If they are not fusing, all the structures will be of double in number. So that you can clearly see there is two uterus, two cervix and two vagina, but there will be only two fallopian tubes. Okay, so this is what is known as the uterus didelphys. Didelphys, everything double. So you are having two uterus, two cervix, two vagina and two fallopian tubes, everything double. What's happening here? There is non-fusion. Okay, the two completely they are not fusing. So everything is double. Now, important points are, see, please concentrate here. If you perform hysterosalpingography, what you can see? You can see two vagina, two cervix and two uterine cavities and two fallopian tubes. So here also you can see everything is double. This is one uterus and one cervix. Here also you can see one uterus, one cervix and one fallopian tube. And here I think you can see it's very clear that there are these two upper vagina, upper cervix, okay, not upper cervix, cervix and the two uterine cavities. This is a 3D, okay, 3D image of the uterus didelphys. And even in the other hysterosalpingography images, you can clearly see all the structures are double in nature. Now, after seeing this, now let's discuss about the class 4 defect. What's happening in the class 4 defect? See, fusion started. Where the fusion started, we all know. The fusion is starting caudally. Okay, the fusion started. For example, let me take something like this. See, this is a one Mullerian duct and this is the other Mullerian duct. See, the fusion have started, but it is not completed. Okay, so because of this non-fusion, okay, started, incomplete fusion I should say. Because of this incomplete fusion, we are having one cervix, because caudal part is fused. As the caudal part is fused, there is one vagina and one cervix. As the upper parts are not fused, there are two uterine cavities. Okay, two uterine cavities are there with the two fallopian tubes. Okay, so there is two uterine cavities, or I should say two uterus are there, but because of the caudal fusion, there is only one cervix, one vagina, and there are two fallopian tubes in number. Okay, so this is known as bicornuate uterus. What exactly is the uterus didelphys, guys? Uterus didelphys is everything double. Two uterus, two cervix, two vagina and two fallopian tubes. What is this bicornuate uterus? Bicornuate uterus is bicornua. Okay, two horns of the uterus are there. Okay, two uterine cavities are there, but only one cervix, one vagina because of the incomplete fusion of the Mullerian ducts. After this, now see some important points. Fusion begins from the caudal end. We all know. As the fusion begins from the caudal end, there is one cervix. Okay, that part which is forming the cervix, it is fused. That's the reason why there is only one cervix. But the above parts are not fused, so two uterine cavities. Now, guys, this is a very important MCQ, guys. What is that? External fundal contour is abnormal. Guys, if you see whole uterus, this is the fundus of the uterus, we all know. What's happening here? The fundal contour, there is a dip over here. Okay, there is this dip in this area. So externally, there is a dip in this area. Why I am stressing this? Why? Because so to differentially diagnose bicornuate uterus with the septate uterus, which we are going to discuss later. If you want to differentiate between bicornuate uterus and septate uterus, see, these are some important points to know. Why? Because in septate uterus, the fundal contour is absolutely normal. That we will discuss anyway later. But for now, please concentrate that the fundal contour is having this dip. So abnormal fundal contour is there. Now, okay, see, the surgery which was done is known as the Strassman's or Jones metroplasty. Metro is the uterus and plasty is the unification. So Jones metroplasty or Strassman's metroplasty is done for unification of these two uterine cavities. And what is the indication to do this unification surgery? The indication is a recurrent abortions MCQ. Okay, so Usually, if there are no abortion, if everything is completely going normal, there is no need of the surgery. But if that female is coming to the clinic with a complaint of recurrent abortions, then this unification surgery should be done. So, indication is recurrent abortions for the surgery. Now, after this, let's see the hysterosalpingographic image. Here, it's very clear that the uterine cavities, okay, there are two uterine cavities, very clearly it's seen, uterine cavities are two. But, guys, very important point is hysterosalpingography. Okay, with the help of hysterosalpingography, you cannot put the diagnosis of bicornuate uterus. Okay, why? Because same septate uterus will look exactly like the same. So septate uterus and bicornuate uterus, they look exactly same on the hysterosalpingography. Why? We will discuss later. Okay, so just for giving you an idea, I am showing you the hysterosalpingographic image of the bicornuate uterus. Now, let's talk about the septate uterus. See, it is a class 5 anomaly where failure in the resorption of the septum. What exactly is this? Guys, the two Mullerian ducts, they have to start fusing from the caudal end and they have to fuse in the entire length. So what happens? So whatever the septum which is present in between these two, for example, if this is one Mullerian duct and this is the other Mullerian duct, whenever they are fusing, the septum which is there, okay, the septum which is there, it should be completely resorbed so that there is only one duct. But what happening in this condition of the septate uterus? They are fused, but this septum is not getting resorbed. So what happens in the uterus? In the uterus, you will be having a septum something like this. So this is the septum due to failure in the resorption of the wall of the two uterine ducts. Okay. Now, so because of this, what happens? There are two uterine cavities. There is only one cervix, one vagina, and two fallopian tubes. Okay, it's very much simple. Yes, there is only one septum. But very important points are the most common uterine anomaly is the septate uterus. Repeatedly asked MCQ. Most common uterine anomaly is septate, followed by bicornuate and arcuate uterus. Now, here please concentrate. The external fundal contour is normal. Again, I am stressing. The external fundal contour in a bicornuate uterus is having a dip something like this. Okay, please concentrate here. This is a bicornuate uterus, you are having a dip something like this. Okay, this is not the septum. Okay, that's not the septum. This is a bicornuate uterus. But here in a bicornuate uterus, you are having a dip here. But please concentrate, guys, here. The external fundal contour in a septate uterus is absolutely normal. Okay, now the septal resection is the surgery by hysteroscopy is done for treating the septate uterus. If there are these recurrent abortions, what you can do is this septal resection. Guys, now please concentrate a few important points from here. From here, the topic is going to be very important. See, if you are having an MCQ from septate uterus and bicornuate uterus, then definitely this is going to be the MCQ. What is that? It's very much difficult to distinguish septate uterus from bicornuate uterus with the hysterosalpingography. We have already discussed that. Hysterosalpingography is not going to differentiate bicornuate uterus and septate uterus. Why? What you are having here, this is a bicornuate uterus. Okay, it's a bicornuate uterus. And this is a septate uterus. Okay, this is the septate. Okay, this is the septum. And this is a subseptum. Okay, see, sometimes you can have a fully complete septum. Okay, complete septum can be there, and sometimes you can have a subseptum. Both of them are the septate uterus. Now, please concentrate that in bicornuate uterus and in septate uterus, the cavities looks exactly the same. Please concentrate the cavity, only cavity, concentrate on the cavities. If I fill these cavities with a radio contrast dye, they look exactly the same. Now let me show you. See, this blue color area, I am filling the radio contrast dye. If I am filling, please only concentrate on the blue color area. They are exactly looking like Y shape. In both the conditions, they are exactly looking the same. So, you cannot differentiate a bicornuate uterus and septate uterus with the hysterosalpingography. Now you can ask me, so we can simply differentiate with the fundal contour. Why? Because the fundal contour here in the bicornuate uterus is bit deep and the fundal contour here is absolutely normal in the septate uterus. Guys, please know that the fundal contour cannot be seen with the hysterosalpingography. What you can see with the hysterosalpingography is only this blue color area, uterine cavities, that radio opaque dye can be seen. But you cannot see the fundal contour. So, with the hysterosalpingography, you cannot, very important, you cannot differentiate between a bicornuate uterus and a septate uterus. So, let's see. These are the hysterosalpingography images of a bicornuate uterus. This one and septate uterus. Now, please concentrate. In both the images, you can see this Y-shaped cavities. Both the images are having these Y-shaped cavities. But let me ask you one question. Are you able to see the fundus of the uterus? No. What you can see is the uterine cavities only. So you are not supposed or you are not able to differentiate between them. Now, but there are certain techniques with which I can say what is a bicornuate uterus and what is a septate uterus. Say 100% I cannot say, but I can at least think about that this might be a bicornuate uterus and this might be a septate uterus by following certain rules. What are they? Please concentrate. If it is a bicornuate uterus, the angle between the two uterine horns will be more than 90 degrees. Means if it's a bicornuate, there will be more angle. Okay, it's not an acute angle. The angle will be more obtuse. If the angle is more than 190 degrees between both the horns, then this is more likely to be a bicornuate uterus. And the distance between the two horns, if the distance between the two horns is more than 4 centimeters, then this uterus is more likely. Okay, this word is very important. So, more likely to be a bicornuate uterus, but I am not 100% sure. In the same way, if it's a septate uterus, the angle between both the horns is more acute. Okay, more acute angle, that is less than 90 degrees. Then I can say this is more likely to be a septate, and the distance between both the horns should be less than 4 centimeters. Okay, so this is how I can say that the bicornuate, this is a more likely a bicornuate and more likely a septate uterus, but not 100% sure. Okay, now, so how can be 100% sure? How can I be 100% sure that this is bicornuate and this is septate? By looking at the fundus. So to look at the fundus, what I have to do? Directly look at it by laparoscopy. So the overall best, please concentrate guys, overall best is laparoscopy along with hysteroscopy. But to look at the fundus, not all the time you need to do a laparoscopy, but you can also do an MRI. Okay, see MRI in this image, please concentrate on these above images. Here, this side is the bicornuate uterus. Okay, in the bicornuate side, you can clearly see that there is this fundal tip. Okay, this is fundal indentation. The fundal cleft is very much clear. Okay, see, this fundus is getting indented. So, with the fundal indentation, I can say that this is a bicornuate uterus. But on septate uterus side, we all know that the fundus is very much normal. We can see a septa over here. See. Please guys, here the septa is very much clear. But what about the fundus? The fundus is absolutely normal. See here, the fundus is absolutely normal and you are having a septum over here. So with the MRI, you can say this is bicornuate and this is septate. But with hysterosalpingography, you cannot. But 100% overall best is a diagnostic laparoscopy along with the hysteroscopy. Like with one camera, you are seeing the fundus of the uterus, and with the other camera, you are seeing inside the uterus. That is laparoscopy and hysteroscopy. But if someone asks you, what is the first investigation to be done? See, for Mullerian anomalies, the first investigation to be done is transvaginal ultrasonography. After transvaginal ultrasonography, you can go with the hysterosalpingography. But here the results are not that much clear. So, you can do MRI. See guys, important point is MRI is the best imaging method. See, in imaging methods, radiological methods, MRI is best. Okay, but overall best is diagnostic laparoscopy along with hysterosalpingography. Okay, so this is something about the radiological test. Now let's discuss class 6 abnormality, which is arcuate uterus. What's the problem with the arcuate uterus, guys? Very simple. In arcuate uterus, there are 2 Mullerian ducts. They have fused completely. There is resorption of the septum. Everything is normal. But the only problem is, see here, this is a normal uterus. Okay, this one is a normal uterus. Please concentrate on the area of fundus. See here, the fundus is a more of a flat here. But see here in this image, the fundus is a bit indented. A fundus is getting indented into the uterine cavity, just like an arc. So that's what is known as the arcuate uterus. There is a mild indentation of the fundal contour, but usually having in this arcuate uterus won't cause any reproductive problems or won't cause any fertility problems. So best reproductive outcome is seen with the arcuate uterus. A worst reproductive outcome is seen with septate uterus. Please concentrate, guys. Having a septate uterus will cause the recurrent abortions. Why? Because see that septum interferes. Okay, let me write it here. This septum interferes with. Okay, let me write. Interferes with implantation. Okay, septum interferes with the implantation. So the embryo might got implanted over the septum. That septum is less vascular and the endometrial lining is not as good as the remaining part of the uterus. So what happens? So having the septate uterus causing problems with the implantation, and that can cause abortions, recurrent abortions. So a worst reproductive outcome is seen with the septate uterus and best reproductive outcome is seen with the arcuate uterus. After this, let's talk about the class 7 anomaly, and these uterine anomalies are due to exposure to the 𝗑𝐼𝐻𝐿silbestrol. See, this 𝗑𝐼𝐻𝐿silbestrol is a drug, okay, synthetic estrogen kind of drug which was used previously, but these days we are not using it because of its adverse effects. See, using this 𝗑𝐼𝐻𝐿silbestrol during pregnancy will cause uterine abnormalities in the growing fetus. Okay, so if mother takes this 𝗑𝐼𝐻𝐿silbestrol, this 𝗑𝐼𝐻𝐿silbestrol will cause uterine anomalies in the growing female fetus. What kind of uterine anomalies we will discuss? Especially, please concentrate here how the uterus looks like or how the uterine cavity looks like. T-shaped. Okay, it's a very, very important MCQ. A T-shaped uterine cavity is seen with in utero exposure of the 𝗑𝐼𝐻𝐿silbestrol. Not only the uterus, cervix will be affected, vagina will be affected. Now let's see. Here, the hysterosalpingographic image is very clearly showing the uterine cavity, which is a T-shape. Here also very clear that the uterine cavity is something like a T-shape. Okay, I think you can appreciate the shape of the uterus which was exposed to 𝗑𝐼𝐻𝐿silbestrol in utero. Now, what are the reproductive tract abnormalities, guys? Uterus will be hypoplastic. So guys, this is very, very important. This is the most common uterine anomaly with the DES. Okay, most common uterine anomaly which is seen with the DES is hypoplastic uterus, or the uterus which is not properly developed. Hypoplastic uterus, you may have a T-shaped uterine cavity. Along with that, you can have constrictions and adhesions in the endometrial cavity. And which is also very important is the perifimbrial cyst. Okay. This perifimbrial cysts can be seen MCQ. T-shaped uterine cavity, hypoplastic uterus and perifimbrial cysts are seen. Now what about the cervix? If I am talking about the cervix can have hypoplasia of cervix. It may present with a collar or hood. See, these are MCQs. Okay, cervix with a collar or hood of the cervix is seen with the exposure to 𝗑𝐼𝐻𝐿silbestrol. And polyps can be seen, ectropion can be seen. This is very, very important. Adenosis of the ectocervix, important. So adenosis of the ectocervix, adenosis of vagina. Okay, please here. Adenosis of vagina, they are seen with the exposure to diethylstilbestrol. Now, vagina can have a ridge, transverse septum, and vaginal adenosis. Why am I talking so much about the adenosis? Why? Because that adenosis may turn into cancer. Okay, so cervical cancer, vaginal cancer can be seen with the exposure to diethylstilbestrol. Apart from that, now let's discuss about the reproductive tract anomalies, which are nothing but the hypoplastic uterus, T-shaped uterus, cervix with a hood, cervix with a collar, vaginal adenosis, cervix adenosis can be seen. Okay, the ectocervix can have the adenosis, a glandular growth can be seen. Now, after this, let's talk about some other important risks which are associated with the exposure to diethylstilbestrol. Now, please concentrate. In utero exposure to diethylstilbestrol is associated with several potential risks in a female offspring, and those female offsprings who have exposed themselves to diethylstilbestrol during pregnancy are known as DES daughters. Okay, these daughters, they don't know anything, but they are just a poor kids who are in the uterus. The mother takes this diethylstilbestrol, and this diethylstilbestrol is acting on this growing fetus. Okay, now they can have these, the DES daughters, they can have this cervico-vaginal clear cell adenocarcinoma. So because this vaginal and cervical adenosis is happening because of this DES, and there can be risk of a pre-malignant condition which is known as CAN, cervical intraepithelial neoplasia. See, this is a cancer, vaginal cancer and cervix cancer. These are the malignant conditions, and this one, cervical intraepithelial neoplasia, is a pre-malignant condition which can eventually turn into a cervical cancer. Now, you can have a benign condition like fibroids, very less risk, but still it's there. Taking this DES may cause fibroids in the female, and there can be a chance of ectopic pregnancy. Why? Because, like, it's having problem with the tubes. Like, there is a hypoplasia of the tubes. Because of the hypoplasia of tubes, the implantation might happen in the tubes, and that can cause ectopic pregnancy. And there are evidences that exposure to diethylstilbestrol is causing a pre-eclampsia in these DES daughters, and there is a chance of earlier menopause in this DES daughters. Means, like, those females who have exposed themselves to diethylstilbestrol during their intrauterine life may end up having early menopause, somewhere around 40 years maybe. So this is very much possible with the exposure to DES. Important MCQ is renal anomalies are not associated with DES. Okay, exposure to diethylstilbestrol in female fetuses or in DES daughters does not associated with the renal abnormalities. A very, very important MCQs. Again, I am stressing, it's a very, very important. Okay, I have completed all the vertical fusion defects and the lateral fusion defects, and also we have completed the whole development of the male and female reproductive organs. I hope the lecture is helpful. Thank you.